again. It's always a nice venue. So let me bring this up. All right, so the topic for tonight is distal junctional kyphosis after adolescent idiopathic scoliosis operations. Somewhat of a niche topic, but it does some of the principles and risk factors that we'll talk about do apply to the adult world as well. Quick outline on the talk this evening. We'll touch upon the background, the prevalence of DJK following AIS operations, discuss the risk factors, how patients may present, and then quickly go over workup, and then also touch upon the surgical considerations and I think bring up some concepts about potential ways of preventing it. As Dr. Bourbon mentioned, we'll talk about 3 cases that will be presented by our fellows, T Sharpman, Rafet Kaiser, and Jay Shaw, and they'll be moderated by Shane Birch, L Metz, and Sig Bourbon. I would like to send out a special thanks to Mohammed Diab for contributing some of his cases, allowing us to air some dirty laundry. And it's always hard to share complications, but it's an important topic, and I look forward to discussing it. So surgery for AIS is an area that's been considerably explored. There's a lot of interest in determining its relative benefits and its utility, but also assessing its pitfalls. Many studies have demonstrated that it does provide improvement in quality of life, particularly in the mental health and image domains, and others, depending on which studies you read, and some of the HRQL outcome measures we assess. And then for patients who may present with compromised pulmonary function preoperatively, there are several studies that demonstrate that it can improve those pulmonary functions after operations. Importantly, though, despite it providing the vast improvements for the vast majority of patients, there are not infrequent times where there are important risks or complications that do occur. I think the most dreaded one, especially in this patient population, those who develop a neural deficit, pseudarthrosis and infection, implant failure, and then junctional pathology that can occur both proximally and distally. From the WashU group, Scott Lumen put out a paper so many years ago that demonstrated a 13% 2-year revision rate, which is quite staggering for this patient population, but it does highlight that it's not without risks. So tonight's topic mainly will be on distal junctional pathology. This can come in a spectrum of disease from mild junctional kyphosis to the catastrophic junctional failure. So distal junctional kyphosis, DJK, and DJF for distal junctional failure. The incidence in the AIS population has been has a quite broad range, less than 1% to about 20%. I would say on average, it hovers around 7-8% or so. There is a quite variable presentation in terms of degree and severity of pain, location of pain, when it occurs after surgery, acutely versus in a delayed fashion, and the mechanism of failure also varies. In terms of the types of failures, I've broken it down into 4 major categories. There's a continuum here, and some of them occur concomitantly. The fractures of the LIV, the lower instrumented vertebra, we'll touch upon briefly in the next slide, because these probably carry the highest risk, and it's important to understand and diagnose them, and also be aware of their potential development and treatment options for them. This can occur most commonly in the acute setting. Those failures that occur in the delayed fashion fall into the category of soft tissue. Disruption may not be the right description. It could be attenuation or just incompetence that occurs over time. Progressive distal disc degeneration also can occur, and then non-union at the last level. So these fractures of the LIV can be quite devastating. It's a chance fracture, a 3-column injury that is a flexion distraction type pattern. You can see on the bottom right there, it's the classic view of it. It's a fracture through the axial plane, right through the pedicle, and can have quite a bit of subluxation or dislocation. It's most commonly acute, but it can occur in a delayed fashion. It can be traumatic or non-traumatic. I think non-traumatic is probably the most common. And then the first report of this, interestingly, was by Boachi et al. Back in 1998. It was in an athetoid cerebral palsy patient. It was in he was 44-year-old gentleman, but it was for a scoliosis. And importantly, it has a very high rate of concomitant neural deficits. And that's the thing to pay attention to the most. This was a nice study from the Minnesota group in Texas Scottish Rite. It's a multi-center review of patients who developed DJK and DJF postoperatively. 15 patients developed distal pathology. 75% of them had this type of 3-column fracture, as you can see on the upper right image there. 2 of them developed severe neural deficits, which improved, albeit incompletely, after revision operations. Those failures that occur in a more delayed fashion, PLC failure or attenuation or stretching out of the PLC over time, as you see on the left, distal degenerative disc disease, as you see in the middle image, and then non-union, as you can see on that far right image, with the hailing of the screws and the broken screws at the level of the body pedicle junction. Brings up the question of what are the risk factors? Why does this occur? Mechanisms? And ultimately, we don't exactly know. It's likely multifactorial, patient to patient. One thing that's well documented as a risk factor is a selection of levels, which we'll go into shortly. I think failure to restore sagittal alignment specific to the patient, particularly in the thoracic spine, probably plays a role in this. Variability of pelvic incidence of the patient, also in terms of sagittal plane restoration, implant rigidity, trajectory of the LIV screw. A straightforward screw may not have as high risk of failure versus an anatomic screw, may put more cantilever forces on that distal junction, vertebral body. The amount of correction, relative magnitude of correction, body habitus, talk about BMI, and then there may be a component of neuromuscular disorders, and there's probably other factors just that we're not aware of at this time. This is a study that myself, I wrote with Dr. Diab, series of patients, most recently looking at the risk factors and costs of revision operations for distal junctional kyphosis following thoracic only posterior implant infusion for AIS. We found that there's a DJK rate of 6.3%, average time to revision approached 2 years. You can see a variability in the standard deviation, so some occur quite acutely versus more chronically. The risk factors that we defined for DJK development were greater BMI, lower postoperative thoracic kyphosis, so failure to restore appropriate thoracic kyphosis, a greater postoperative lumbar coronal cob angle, and then lower instrument and vertebrae that were cranial to the sagittal stable vertebra, the SSV. The sagittal stable vertebra is something that is important to understand, especially in this concept. It was defined in the setting of Sherman's kyphosis as the LIV touched by a line drawn vertically from the posterior superior corner of the sacrum on the lateral radiograph, as shown on the right. It's akin to the selection of the LIV on the coronal plane image. There have been several studies that have evaluated this as a risk factor for DJK development in AIS specifically. This was a study from Dave Skaggs while he was at USC, and found that the rate of DJK, DJF significantly higher when the LIV was cranial to the sagittal stable vertebra, 17% versus 0. They also reported that as the LIV was more cranial from the sagittal stable vertebra, the DJK and DJF rates increased. So if it's one level above the sagittal stable vertebra is 70%. You see there at 3 levels above the sagittal stable vertebra, approach 50% rate of DJK and DJF. More recent study 2 years ago by the HARM study group led by Mike Vitale, studying a pretty robust patient population in their study group, nearly 856 patients. The incidence of DJK, as you can see, noted there, when the LIV included the sagittal stable vertebra, 7.7%, and the LIV was cranial, the sagittal stable vertebra approached 50%. They also found that if the LIV was short, cranial to the sagittal stable vertebra, the DJK risk at 2 years for those patients who had modifier type B or C had a 9.2 times increased risk. Another study by the HARM study group looking at 5-year postoperative development at DJK and DJF also demonstrated that predictive value of LIV relative to the sagittal stable vertebra. So when the LIV was distal to that vertebra, 2.2% DJK rate, where if it was cranial to the sagittal stable vertebra, 15%. Now, stopping or including the sagittal stable vertebra is it's not the panacea to prevention. You can see there at 6.5% rate of DJK. So there are other factors at play here. When we look at the revision operations and talk about things to consider when approaching these distal pathologies, it's important to note that these are more complex operations than revision operations, than primary operations, for a variety of factors. Even though there's fewer levels of fuse, you may have to do a decompression. Rarely is a 3-column osteotomy needed because of the flexibility of the spine, but just does carry higher risk. When considering a new lower instrumented vertebra, for those that occur after a thoracic-based posterior instrumented fusion, usually extension to the mid-lumbar spine, L3 or L4 seems to be most common approach. For DJK that develops below a thoracolumbar posterior instrumented fusion, extending the low lumbar spine is preferred in a young patient. Hopefully we can save the pelvis. If you don't have to extend down, it can just revise that most distal level. That could also be of benefit, especially in the young patient population where you want to preserve as much motion and fusion levels as possible. Many of these operations include anterior column support. It's important to have, asking the reps and having all the options available for revisions, Z-rods, and then connectors, lateral connectors, etc. So just a couple quick case examples. This is a patient that we saw previously with the screws that were broken and the non-union at the lower instrumented vertebra. This was addressed by a T-lift at that bottom level and extension down to L3. You can see there with the Z-rods, overall the patient ended up doing quite well. I think the risk factors, if we talk about it, patient was slightly overweight, had a hypokyphosis postoperatively, and over time that distal level probably felt a little bit too much stress. In terms of this patient, and again, I think hypokyphosis of the thoracic spine probably was the etiology here. Can see here inline domino. Now, this was a 17-year-old girl, liked to swim. So I was asked to help with this revision. And so it didn't want to extend her down to L5 or even to the pelvis because swimmers need a lot of pelvic motion, especially when making their turns. So we addressed this by doing a direct lateral interbody fusion at the bottom level, upsizing the screws and connecting up to the prior instrumentation. We cement, augment, discussion point in our discussion session. We looked at the cost of these revision operations in the study I presented.
Alekos, your signal's coming in and out a bit.
Oh. Maybe
it might be a connection issue. I think we can hear you now, but
I assume everybody's having the same problem. I lost him for a little bit as well.
Yeah.
Sorry about
that. Carry on, Alekos, but if it happens again, then I might walk through the rest of your slides because you got a great presentation here. But go ahead and see if we can get you through it.
Okay, great. Let me try one thing. I'm going to turn off my video.
Good idea.
Yeah, Lionel, thank you for that recommendation. You guys want me to go back?
No, I think you're good here, Alekos. You've been keeping up well. It just happened a few times.
Okay, sorry about that. So in the study that we had talked about before, we looked at the cost of these revision operations, and despite having fewer number of levels fused, these revision operations were more invasive than the index operations, longer OR times, greater blood loss, and ultimately longer hospital length of stays. These factors resulted in significantly greater direct costs across the board: anesthesia costs, OR services, blood transfusions, pharmacologic medications, implants, labs, PACU, et cetera. And when we look at the total mean direct costs were significantly greater for the revisions. The average direct costs, you can see 76,000 compared to 7,000 for the index operations. And for 7 revision operations amounted to $538,000, which was 15% of all total direct costs of all the index operations. So quite costly in terms of the revisions that these require. I think that really brings us to the point of prevention is the key, but how do we do it? And we talked about alignment-based techniques, appropriate level selection, including the sagittal stable vertebrae we saw there. That is not the panacea for prevention. Restoration of appropriate thoracic kyphosis, that's not always possible, just given the rigidity of these deformities and all the other factors that we talked about. It brings up the question of prophylactic instrumentation strategies at the LIV for higher risk patients, the patients who are obese, maybe have higher deformity corrections. Do we augment the lower instrumented vertebra? Something that we've done more in the adult population. Do we do an interbody fusion right off the bat between the LIV +1, so the level cranial, and the LIV? Do we provide sublaminar banding versus hooks versus wiring at the LIV? If you talk about those flexion distraction injuries or those chance fractures, it's really a failure, kind of through the pedicle. And maybe if we fixate a little bit more distal on that lamina, it may prevent that. Will that transfer the stresses to the joint below? I think that will be determined. There is a study, biomechanical study, that was done out of Boston Children's cadaveric model many years ago that did demonstrate that sublaminar hooks do provide a nicer biomechanical environment for that LIV level. It's also been demonstrated in the burst fracture literature that saving a level by putting a sublaminar hook does provide good biomechanics. It's the equivalent of going.
Alekos, we lost you again.
All right, Alekos,
The 3-column fractures. Having trouble, Sig?
yeah, we lost you again. Well, you're back on now. Maybe go ahead. You're going well for a while. I think you're near your conclusions here. So
Yeah.
then we'll make.
So variety of presentations, 3-column fractures have those associated neural deficits. Please pay attention to those. There's also the delayed etiologies is listed there. The risk factors are multifactorial, poor level selection, cranial to the sagittal stable vertebra. Obese patients are higher risk, and inadequate sagittal alignment restoration. Revision operations are more complex than the index operation and are quite a bit more costly. And prevention is a key, but strategies that hold utility are poorly understood and evaluated. I think more research is needed in that arena. So sorry about the connection, guys. Hopefully you found some benefit from it. And before we head into the interesting cases, any questions?
Yeah, I have a question. I'm assuming that you optimize their bone health in all these patients.
Yeah, I think that's an area also of future studies. The patients with AIS.
Awesome, Sig.
Yeah, Rick. So what are you going to say there is that these are mostly adolescent cases, and we're not routinely doing DEXA measurements on the AIS cases. Having said that, we do know that there's a high prevalence of certainly vitamin D deficiency on this population. I think certainly some of the neuromuscular cases and some of the patients who maybe maybe more sedentary, we probably should be being more proactive about measuring bone density. In the majority of our AIS cases, we're not routinely measuring bone density. I don't know if others are doing that.
And so what are the average age of the patients?
So the profile we're showing here, these are primarily adolescent patients. So these are going to be kids between typically the ages of 14 to 17. So we'll go through these. DJK is a problem in both the adolescent and the adult population. And I think it's something that we've been so focused on the proximal that, but the prevalence of distal kyphosis and distal failures is actually quite similar. Maybe what we'll do is go through some cases and but I think bone density optimization is part of it. I think Alekos made a very strong point about circumferential fusion. And a big part of what we tend to focus on is choosing the right lower instrumented vertebra and really trying to include that lowest touched vertebra by the posterior sacral line. I think Rafid's got the any other cases, or Alekos, if you're back on, feel free to speak up.
Yeah. Do you want to share your screen, Dr. T? If not, I have them ready here too. And I think.
Yeah, I'm
go
here.
ahead. Okay, go ahead and share, and you can advance with their command that you need to share.
It might be better if you do it, Linda, because I think we just got a message his Wi-Fi is low.
Okay. All right. Can you advance to the next one, Dr. T? And then Dr. Sharpman.
Right.
Hi, everybody. Thanks so much for having us this evening. I'm Zach Sharpman. I'm one of the current fellows at UCSF this year. I'm going to present our first case. This is a 13-year-old female who presented and was found to have adolescent idiopathic scoliosis. You can see her curve magnitude here. She has a 78-degree main thoracic curve, 47-degree proximal thoracic curve, and a 53-degree thoracolumbar curve. You can see that my line measurements here are showing 42 degrees of thoracic kyphosis. That being said, we know that these X-rays oftentimes can overestimate it, and AIS is a disease that comes with hypokyphosis of the thoracic spine. And she's measured to have 48 degrees of lumbar lordosis on this imaging. Her stable sagittal vertebrae, or that line that touches the posterior, the last vertebra that touches from the posterior aspect of the sacrum, is L2. Next slide, please. She was indicated for surgery and underwent a T3 to L1 posterior instrumented fusion. You can see this construct used both Lukey wires and pedicle screws. And the LIV was one level cranial to the stable sagittal vertebra at L2. Patient actually did well post-operatively for the first 17 months. Advance when you're ready, please. But unfortunately, she presented back to clinic with a non-traumatic 3-column chance fracture at the LIV. You can see on the sagittal X-ray here, the lateral X-ray, there's a significant sagittal plane deformity focused around that lowest instrumented vertebra, and you can see the splaying of the pedicles here on these sagittal CT cuts. Next slide, please. The decision was made to revise her, and that was done with a anterior lumbar interbody fusion to circumferentially support the spine, and an extension of the fusion down to L3 with posterior instrumented fusion from the back. Unfortunately, 3 months post-operatively, this patient had a recurrent distal junctional failure. You can see that this was then revised again with direct lateral interbody fusion at L2-3 and L3-4, and an additional extension of fusion. You can see the final construct on fluoro here on the right. While in the hospital, the patient developed new leg pain and weakness, and a CT scan demonstrated a additional 3-column chance fracture at the new LIV, which was L4. You can see the splaying of the pedicle there, and likely vertical foraminal stenosis from this kyphotic deformity. Next slide, please. The patient underwent an additional, during the same hospital stay, an extension of her previous fusion to the pelvis with a L2 to 4 decompression, as well as anterior column support from an anterior lumbar interbody fusion approach. And she had resolution of her leg pain and weakness. Fortunately, at 4 years postoperatively, she's intact and she achieved union. But obviously, this is a very complex case that involved a unideal trajectory of events until she has achieved the stable construct for the time being.
Rafa, let's go back to the first failure. So to the fusion down to L1, and maybe Alekos, we could have you comment on the LIV choice of L1 versus L2. This is I think I was actually involved in one of these revisions, perhaps the last one, and maybe Alekos, you were involved in one as well. But I wonder, in terms of the early failure, you had talked about 3-column injuries, and maybe we could just show how this was a 3-column injury with that chance fracture through L1.
Yeah, so just in terms of the sagittal stable vertebra, so you can see here on the coronal that the LIV selection, I think, from an L1 perspective was appropriate. But we looked at the sagittal. If we draw that line from the posterior superior corner of S1, it goes through the front inferior corner of the L2. The L1 is posterior to it. So consider this, the LIV stopping at L1 cranial to the sagittal stable vertebra puts them at quite a bit of risk. I think one of the other risk factors here was the thoracic spine was in hypokyphosis postoperatively, and then this is the 3-column fracture that we see here. You can see here it's kind of through the pars, a little bit below. It's not as not through the pedicle, but right below the pedicle through the pars, and you can see that fleck of bone in the inferior posterior corner of the disc. But clearly an unstable injury. Again, it happened 17 months post-op and atraumatic. Just, I think, over time, this area fatigued and the bone just couldn't tolerate that stress.
This patient, I recall, was a very heavy young lady. Did we know anything about her bone density, either Rafa or Alekos? Did we have any information on that?
Unfortunately, she did not have a DEXA scan preoperatively, but I saw on the chart that I believe she was vitamin D deficient and eventually underwent treatment for that.
So Jens is bringing up a question in the chat, which is an important one, is what about the use of a TLSO in a AIS case? Certainly that's something we're commonly doing in our adult deformity. In our AIS work, and maybe Lionel, I'll ask you to bring this up as well, but I'm not routinely putting our AIS cases into a TLSO. Lionel, what's your policy bit on that?
I actually am. It's not, studies have kind of not borne out that it's, I think, a strong evidence-based recommendation, but I found that my patients generally are more comfortable in the TLSO. I think it does help them sort of reestablish proprioception in terms of the coronal and sagittal plane a little bit faster. So in the patients I have done it, and I use a hard anterior overlap TLSO, I think those patients tend to find their balance a little bit faster than those I haven't done the TLSO. But again, not evidence-based, but that's what anecdotally I found in my practice. There was, an important point brought up in the chat that it's not recommended to perform a distal orthodesis in the dorsal-lumbar transition or the thoracolumbar transition between those curves. And I think that's an important point as we start to talk about the stable sagittal vertebra, and that's a concept that was well established for Schurman's and kyphotic cases, but we have to be careful as we think about, bringing fusions down towards the stable sagittal vertebra, that we're not, stopping the fusion in the middle of the compensatory curve, because that has its own pitfalls in terms of coronal decompensation.
Yeah, I think it's a very important point, especially our type 3 curves, where there's a structural curve in the lumbar spine, thoracolumbar. Jens, what about you? Are you using a brace now at TLSO postoperatively for your adolescents with scoliosis? You asked the question.
Humbling story, yes. So this is a very perplexing case, and I don't fault the surgeons for kyphosis reduction, etc. But I look at the body mechanics of patients, and as much as I feel happy with my fixation, all that, if patients have a bad body mechanical composition or are unreliable, I just, for my own protection, for a CYA, basically have gotten to braces. I've had people tear their hardware out either which way by being pulled up on their arms out of their bed. I had one patient not too long ago have that done, and it's just pretty frustrating. So I think this is just an external warning sign to not go crazy. And I liked Dr. Metz's thought of it just kind of gives the patient a better proprioceptive transition to be respectful of their mobile segments relative to the rigid zone. But this patient still puzzles me because it's that shouldn't happen. I agree that there's no evidence base whatsoever to put AIS patients with a nice thoracic fixation into that. There's some metabolic problem or a neuromuscular proprioceptive disorder in her. So thanks for showing that.
Well, great. So let's move on to the second case. It's going to be presented by Rafid, one of our fellows, and moderated by Dr. Metz. So take it away.
Hi, good evening. Thanks so much for having us back. My name is Rafid Kaser. I'm one of the fellows. This is a case of Dr. Lionel Metz, like Dr. Theologis mentioned. This is a 32-year-old non-binary patient who had undergone many years ago a T5 to T12 posterior fusion for AIS when they were age 12. They have had persistent back pain since. They also complain of prominent hardware at the top of the construct and pain limiting daily activities, even personal hygiene. Past medical history, significant for adjustment disorder, PTSD. They are obese, BMI is slightly above 30, and they have Social Security for disability. They smoke e-cigarettes. And on physical exam, they're positive sagittal balance. They have asymmetric shoulders, tentative palpation over the T4, the top of the hardware. Neurologic exam was intact. X-rays show, these are long-standing films. We see the prior screw and rod construct in the thoracic spine. We see, if we go to the next slide, we can see some angles. We can see slightly unbalanced curves. There's a lumbar curve of 55 degrees, thoracic curve of 49 degrees. There's also a fractional curve below. The patient is tipped over to the left, 2.5 centimeters. And on the sagittal, they have hyperkyphosis in the thoracic spine and have positive sagittal balance of approximately 5 centimeters. Further workup was done, an MRI in addition to the CT scan. The CT scan, we see representative slices of solid fusion mass. There's no real evidence of loosening. I'm sorry, I said screws before, these are hooks. No evidence of loosening, no evidence of pseudarthrosis. And then an MRI was performed that showed no central canal stenosis. There was slight foraminal stenosis at the concavity of the lower lumbar curve. So this patient underwent a revision posterior spinal fusion from T5 to L4. The decision was made to avoid the pelvis in this case and correct her overall balance as well as her sagittal, their sagittal balance. The surgeon, Dr. Metz, did cement, augment L3 and L4, which he does routinely, the two bottom instrumented levels. And the patient did well in the hospital. until 6 weeks postoperatively. They were in physical therapy, and they complained of immediate low back pain during physical therapy. An X-ray was obtained in the clinic, and we see increased forward tilt. No obvious fractures on this X-ray, but then a CT scan was obtained, and you can see in the top right corner of this slide coronally oriented pedicle fractures that were non-displaced here. So the patient was readmitted to the hospital, and the plan was to extend the fusion in a staged fashion. So we did basically an XLIF, a direct lateral at L3-4 and L4-5, the level below. And we see some correction of the alignment in this fluoro shot. And then the next 24 to 48 hours, we extended them to the pelvis with an L5 to S1 transforaminal lumbar underbody fusion. This is the end result. And if we go to the next slide, we can see the 3-month X-ray, standing X-rays. The patient's very happy. Pain is improved. They're currently still in physical therapy, but doing much better. We did put them in a TLSO, and they've been walking with no issues and are logically intact. I believe that's the last slide. Thank you very much.
Thanks, Rafit.
I have a quick question. So Sig mentioned earlier that a lot of these cases started off as adolescent idiopathic scoliosis. Are we looking at outlier distal junctional failures, or is this like 20%? I mean, what kind of are we looking at here in terms of numerator and denominator?
That's a good question. I would have to defer to my more experienced attendings. It's certainly, in my year of fellowship, this is, I think, the only distal junctional failure I've
Well,
seen.
that's an unfair question for you, but for Sig, or Jens, or Alekos, or Lionel, what do you tell your patients?
Yeah, so good question. I think, in terms of the adolescent population, Dr. Theologis had a few studies in his presentation that it looked like the rates were anywhere from kind of the, a few percent up to the mid-teens or so. In my hands, I have actually a series of maybe 4 or 5 young adult patients between about 24 years old and 40 years old. So this population where we don't want to fuse to the pelvis, the pathology ranges from Schuurman's kyphosis to adult idiopathic scoliosis, who have had fusions to L4. And early on, maybe a couple years into practice, I recognized this pattern of these patients having pseudoarthrosis, primarily loosening of screws at L4. And so I've gone to, in my practice, augmenting the LIV, and then including a staged lateral. So usually I'll bring them back 4 to 6 weeks later to do a lateral. And this patient unfortunately fractured before I got her back in for her lateral, but or for their lateral. But I think it's not uncommon. My sort of take on it is these are patients with the disc health is different than our adolescent patients. So we put them on a table in relative lordosis in the lumbar spine and fixate their spine in that position. When they stand up, their disc is not supporting the anterior column the same way that it would if they were 12 or 13 years old. And so I think there's immediate strain on the LIV. Some of that's mitigated by cement augmentation, but I think probably for patients with any significant disc degeneration where that disc is used in a lordotic position, you really should think about doing anterior column support with a interbody.
Jens has got a hand up there. Jens.
So to answer Scott's question, I think based on the old guy's perception, distal junctional failure incidence is 100%. certainly in patients who have 2 to 3 levels preserved after AIS surgery, I can have a whole practice literally out of those patients. I should write them up on a new base. Sig has a lot of gray hairs also, so I think the two of us as gray hairs can probably concur on that. If you've left 2 or 3 levels alone, all those patients come back in their at latest 50s to 60s with pretty significant caudal disease and end-stage arthropathies. It's a little bit less prevalent if you have 4 or more levels. And this is, again, I think also the current fashion of pediatric colleagues is to try to leave caudal levels unfused, even if they're not perfectly balanced, in the interest of just allowing that collagen chain to kind of wiggle a little bit more. So I think overall the answer is 100%, but the surgical conversion maximizes if it's left about 2 or 3 motion segments caudally. Sig, what do you think?
Yeah, I agree. I think fundamentally over the course of time, we're definitely seeing distal junctional changes where a classic paper actually by Levine out of New York showed that stopping at L3 results in better outcomes, better function than L4, than L5. But having said that, I think any of these lower lumbar levels can be problematic as well. So it's not just that stable sagittal vertebra, but it's also getting into that lower lumbar spine and leaving so few levels. So we've got to be so critical, especially this was a young adult. So being awfully critical of what's happening at the LIV +1, or in this case, LIV -1, right? What's happening below the LIV with regard to the posterior facets, the disc. And it's a challenging problem. And that's why I'm glad Alekos chose it.
Sig, can I ask you a real arthroplasty question? 20 years ago, Dave Bradford and Bart Sachs got an exemption from the FDA to put in pro disc at L5S1, and I'm not sure about L4-5 below long AIS fusions. And I just was wondering whether you inherited any of those for long-term follow-up and could give us an idea whether that is an option.
Yeah, Jack, we talked about that in a few cases about doing a disc replacement below a long fusion, and specifically 4-5 and 5-1. We had a series, we looked at long fusions to L5, 25% of them required revision within 5 years, which is, I think most would agree, unacceptably high rate. I'm not aware, I certainly did not do any cases with the disc replacement below the level. I'm not aware of any that were done here. I know Larry Lanky and I talked about a case that he had done with a good outcome, but golly, what are your thoughts, Jack? If you were going to put a disc replacement below it, presumably a more constrained disc, but what are your thoughts about doing that?
Yeah, I mean, it's just based on an N of 1. One of Bart's patients that I see every 2 or 3 years who's breaking down, but she's 20 years out now and gets a rhizotomy every 2 or 3 years and does fine for 2 or 3 years. So based on that small number, it's a better outcome. But I was wondering whether Dr. Bradford had done more patients and they were still, floating around UCSF for you guys to see.
Yeah, I think we had the permission, but not necessarily the audacity to do it. Just very briefly, I think the one thing I'd be concerned about, Jack, and I think you'd agree, is the patient with a higher pelvic incidence, patient with a higher sacral slope. I'd be awfully cautious about a disc replacement there. I think I'd choose somebody who's got a relatively horizontal sacrum and a relatively low pelvic incidence.
It's a question.
That's true. I mean, that we take that into account with even virgin 5-1s for disc replacement. Totally. But to follow up on Jack's point, what's better to have, some motion at 5-1 requiring interventional pain management, rhizotomies once a year or whatever, or what we see more frequently at TBI in the adult scoliosis are these, heavy metal, fusions to the sacrum with bedrock procedures and things like that. Is that a better solution, or leave motion and then have to continue to treat it with whatever?
Yeah, I will say, Scott, really good point. And one of the things we're really protecting against by leaving motion down low is obviously the proximal junctional kyphosis. And one of the reasons we see so much variation in PJK rates in the literature is that in all of our published studies at UCSF, we had patients who were fused down to the sacrum. Our revision rate was 12%, our PJK rate was 20%. But having said that, in patients who aren't fused to the sacrum, the risk of PJK is very, very low. So we're really protecting the proximal segments. And I agree, when we can, preserve motion makes sense. Again, I'd avoid it in a high pelvic incidence, high sacral slope.
We'll try to remember to ask Terry Marnay about that next week, because if anybody has done it in some numbers, it'll probably be Terry.
I think Terry has a different view on that. I've not done anybody has been fused adjacent to the level of disc replacement. I've done a couple L5S1, but usually they've had 4-5 or 3-4 and 4-5 open in between. It's a lot of forces for a long fusion to put on a single disc. And it'll be an interesting question to ask Terry or Karen or Rolando if they've done anybody that has just one open level. It's a nice solution if you can get away with it.
Yeah, there was.
Let me just quickly say, our TBI colleagues have put together a historic thing next Tuesday. We have a great audience tonight, phenomenal cases by UCSF, but please, all of us, dial in. This is historic what you guys have done. I'm really excited about next Tuesday evening. So thanks for putting that on, Scott, Rick, Jack, Izzy. Very excited.
Super. Well,
Question on the chat room about pelvic sacral slope, what kind of the cutoff is for disc replacement. And at least for sacral slope, I think, and Rick and Jack can chime in, most of us agree 45 degrees.
Yeah, that would be right, Scott.
That's even 35.
I think that's what Terry would say too.
Let's not hijack their presentation. Let's we'll talk about this next week.
That's right. We're talking about.
We got one more case here. That's fine. And I'll just very briefly answer that question. I'd be really reluctant as somebody who was into Rousselet type 1. We could talk about it more next week. But I would say a pelvic incidence of less than 55 and a sacral slope of less than 30 is what I'd say. But maybe I'm being too cautious. Let me have Dr. Shaw. Jay Shaw's our third fellow presenting tonight, and Jay's going to show another AIS case with a distal junctional problem that I think will be provocative of some conversations. So go ahead, Jay, take the screen.
Great, thank you for giving me the opportunity. So for the last case, it's a 14-year-old male with AIS, presents with obesity, a BMI of 34. A physical exam, prominence on the right side of the thoracic spine, prominence left side of the lumbar spine, and he's neurologically intact. These are full-length standing AP lateral X-rays. The measurements are on there, but there's a thoracic apex curve right-sided of 45 degrees and a lumbar apex curve to the left of 70 degrees. And the sagittal stable vertebra is at L1 in this case. The next slide shows the side bending films, which shows a decent correction of the lumbar curve to about 40 degrees there. So the plan was to do a T3 to L4 posterior spinal fusion with some osteotomies. There was no complications or changes to neuromonitoring, minimal blood loss, and post-operatively, the patient was neurologically intact and doing well. And then, according to the notes, the patient was working with physical therapy on post-op day 1 and felt a pop in his back and was evaluated to have new neurological deficit, especially in the tib and EHL on the right and left side, and decreased sensation throughout distribution. So a CT scan was obtained, which demonstrated pedicle fracture worse on the left side, which is shown on the next slide here. So an example of kind of 3-column injury, this one happening very soon after the post-operative day, basically post-operative day 1. So you can see the fracture there. So the plan was to do a 2-stage procedure, stage 1 being a revision of the posterior fusion with removal of the L4 instrumentation and decompression due to his new neurologic status, and extension of the posterior fusion to the pelvis, as well as to do L4 to S1 anterior lumbar invited fusion as a stage 2 procedure to give anterior support. So this is the X-rays after the first stage revision fusion with removal of the L4 hardware and extension to the pelvis. Patient after stage 1 still had a neurological deficit, especially on the left side, tib and EHL, both zeros. There was an MRI which was obtained to rule out any hematoma or other compressive pathology, and nothing was found in that MRI. So the patient, they moved on to the second stage procedure, which is L4 to S1 anterior lumbar antibody fusion, which you can see here. Perfect. And then next slide here. Post-op day 1 after stage 2, patient still having neurologic deficit and has improving sensation from before surgery. Patient unfortunately did have some drainage from his posterior wound on post-op day 7, elevated inflammatory markers. So he was taken back with both spine and plastics for wound IND and then closure with paraspinous muscle flaps. Patient did very well after that surgery. This is his 1-year follow-up X-rays and now has 4 out of 5 strengthened bilateral extremities. So did regain his neurologic status after this unfortunate issue.
So tough series of cases here. Lionel, you want to comment on this one?
Sure. Maybe we'll start by going back to the initial post-op. I think, as has been said here, I think one of the hardest or most difficult things to do is balance the sizable plane. I think particularly in this case where you have kind of a thoracolumbar curve. I don't know that. Let's see the post-op there.
I don't think there's any post-op.
Oh, there's no initial post-op?
Because it happened post-op day 1.
Oh, okay, got it. Happened before the post-op film.
Yeah.
And then keep going. The next slide. Yeah. So yeah, I hate to say I don't know if I can identify a risk factor. There is a bit of thoracic kyphosis, but you know, I think potentially bracing the patient may have delayed this, but it may have happened anyway. I don't know exactly what the risk factor was here.
I think the point that Alekos had made early on with the lecture is that these are often 3-column injuries, and I think this is the first one we showed that actually had a significant neural deficit, which it can be common with these type of injuries. You know, again, getting down to L4, that was a neutral and stable vertebra. It certainly was well placed with regard to the posterior sacral line, and I think some of the take-home messages here, this again was a somewhat obese patient, I believe. Looking at bone density, I think maybe in some of these cases, especially the atypical curves might be important. And as Jens suggested, I think maybe trying to recognize if there's a neuromuscular component to some of these atypical curves. I think
this is Izzy. Can we go back to the bending films for a moment, please? So this is something that I struggle with all the time, and I wonder if you guys do as well. Look at 4-5 level as you bend right to left. That just does not move. That disc is not a compliant disc, and I wonder if that had anything to do with the force transmission as you start to straighten the spine. You're changing the vector that's going through the pedicle with the pedicle screw right across. And maybe that's what we're missing on this. And then the discussion becomes, well, do you stop at 4 or go to 5? And I don't know what the answer is, but you see that 4-5 disc just does not really move at all. That's not a compliant disc for whatever reason.
You know, Izzy, I think that's a really important point. And in the adults, so often, I think this was a 14-year-old, but in adults, so often we see that stiff fractional curve. That curve from 4 to 1 is much stiffer than the rest of the curve. But I actually recently had an adolescent in whom, and this might be a case like that, where I think that 4 to 1 can actually be the driving curve. And I wonder in this case, given the flexibility of that thoracolumbar curve, if this might have almost been approached, as you suggested, as horizontalizing the L4, and then you know, on the bending film, that 11 to 4 doesn't look that bad, and Now, I wonder when it's that fixed, if horizontalizing L4 with a 4-to-1, that's the approach I might have used in an adult with this problem, and it might be appropriate even in a 14-year-old. I don't know the answer to that, but I've only actually done that once. One of the other comments here. So why did this happen? I think Izzy points out that the L4 probably wasn't really a neutral, stable vertebra. You can take a 14-year-old down to L5. That's a tough threshold as well. So there really wasn't a good LIV here. And then somebody asked the question of why not do anterior spine fusion in the first place. I presume the question is why not do something like an 11-to-3, recognizing that this is really a thoracolumbar major curve, and that upper thoracic curve might not have been as structural. And well, what are your thoughts about that, Lionel? Maybe just addressing the thoracolumbar curve with an anterior surgery.
I think it's actually a great point. It's not something I had thought about, looking at this case, but and the one thing it doesn't address is the thoracolumbar kyphosis. But I know we think about thoracolumbar kyphosis as a risk factor for junctional problems with posterior surgery, but it's not well, understood whether it's as big of a risk when we do anterior surgery, since we leave the posterior soft tissues intact in those cases. But and I know that the surgeon who did this does do anterior surgery, so that may have been something he considered but decided not to because of the patient's overall size. Looks like the patient's somewhat obese.
Maybe obese for California, but not for Texas.
Yeah, 34. I was like, I wouldn't even blink at 34.
Alekos, I think we're just about out of time here. Why don't we give you the last words as our host?
Yeah, thanks, guys. Sorry we had issues with the connection there, but yeah, again, always a pleasure to present to you all. I'm glad you hope you liked it, and looking forward to the next time we join you, and we'll definitely